Unfortunately, this is the only slide in Italian. Therefore, I have to switch now to English. But if I keep on invited to smart meetings, I'm pretty sure that I will learn sometime also the Italian English, because this is a very attractive language. Thank you for the invitation again. I don't have any conflict of interest too, and this is the agenda. I will try to focus more on the question whether there is a difference of the approach for the fluid management during the one lung, during thoracic surgery, during one lung ventilation, and therefore there are three main questions. First of all, I will deal with the question why the fluid management is more challenging during thoracic surgery. If you start with your residency in the anesthesia, you will hear, you have heard from your masters that you have to give as less fluid as possible during thoracic anesthesia. This is a fact. This is still correct. But the possible explanations that you can hear from your master, from your chief, two of them are there. These are probably wrong. First of all, you will hear something about the famous study from 1984 regarding the post-pneumonictomy pulmonary edema. Post-pneumonictomy pulmonary edema is a wrong concept, and although it is a famous article, it's not only regarding about pneumonictomies, it's all about the thoracic surgery. And in this study, there were only 11 patients, and in this 11 patients with a post-thoracic surgery lung injury, the lung injury was associated with huge amounts of fluid that you would never give nowadays, and therefore this is a probably wrong explanation for your approach for the fluid management. Regarding the third space is a myth. It's probably a myth. So if you are told that there is no third space in the lung and in the thorax, you can ask where else is this lovely third space, and it is probably nowhere in the body. It was a mythic explanation in the recent decades for the physicians who do not know where the huge amounts of fluids that we give is going, and that was probably the third space. Possible explanation for third space is coming in the next slides. Still, it is the fact that we have to give as less fluid as possible during thoracic anesthesia, because it is very probably one of the probable causes of post-thoracotomy lung injury. And therefore, as a quote of Peter Slinger, with intravenous fluids, with more fluids, we do not cause a post-thoracotomy lung injury per se, but we can make the post-thoracotomy lung injury worse, and therefore it is one of the probable reasons. Now we have better explanations for this fact. But first of all, we have a lot of studies showing that less fluid during thoracic anesthesia is a good approach, is an appropriate approach. If we look for the average of the studies, we can have a very significant difference in the amount that has been given if the patient has a postoperative pulmonary complication or not. But there are still no randomized controlled trials regarding the fluid management during the thoracic anesthesia. And we will probably have also no correct randomized clinical trials too, because it is ethically very difficult to organize such a study. Still, we have multivariate analysis from some 10 years ago, and the authors could show that there are two independent risk factors for the lung injury after lung cancer resection. One is the increasing perioperative fluid administration, and the second one is the decrease in postoperative predicted lung function. And here we can see with every 500 mL of perioperative fluid, the odds ratio of having a postoperative complication increase with 1.17. This is not too much, but still statistically significant. The only question that we have to ask regarding this retrospective analysis is the very classical chicken egg question. So the question is, if the physician, if the anesthetist gives some 500 milliliters of fluid more to one patient than the other one, why? What is the reason of this approach? Probably this patient has, although this is an independent risk factor, clinically it can have also some other reasons that drives this anesthetist, gives some more fluid to this patient. And therefore, it's always a chicken egg question regarding the studies. And unfortunately, we will also probably do not have any clinical trials. So why it is the case that more fluid makes it worse? We have now two more scientific than the third space explanations. One of them is endothelial glycocalyx. Edmund Cohen has mentioned already a lot of this glycocalyx. And what is this glycocalyx? Normally, we have this famous Starling equation that we know from our medical schools. But the Starling equation can fail sometimes in explaining the destiny of the fluids that we give. And this is probably also the reason why we have created this concept of third space, because we couldn't explain the destiny of the fluids with the Starling equation. And therefore, there should be something more than the Starling equation. The Starling equation is valid only if the glycocalyx is stable and viable. If there should be a damage, a disruption in the glycocalyx from any other reason, including the surgery and ischemic perfusion, and also rapid intravenous IV fluid infusions. If there's an injury of the glycocalyx, you can forget about the rules of the Starling equation, because everything there is getting something somehow wrong, out of order. And therefore, this is the explanation why we have here actually maybe this historical myth of third space. This is actually the injury of the glycocalyx layer. Why it is so important in the lung and not in another organ? Because the glycocalyx in the lung tissue and in some other tissues is somehow different than the glycocalyx in some other tissues like endocrine organs or gastrointestinal tracts. If we have a damage here, the consequences of this damage is more important, because we have here in the healthy subject, we have here a non-fenestrated capillary of glycocalyx, and therefore it is more important. Moreover, we are working in the lungs, and the surgeons are working also in the lungs, and therefore we would have, during the thoracic surgery, some more important and more dangerous consequences of the glycocalyx injury than in any other operation. This is not enough. Only the glycocalyx injury is not enough to create some lung injury, but we have also this multiple hit theory. This means if you have only one hit, which would be not very dangerous and risky for the lungs, for the lung injury, we need to have another one. And this is actually per se the lung injury, the lung surgery. They are working there, and they injure the lung, the surgeons. So we have one hit of lung surgery. And if we create on the anesthetic side a second injury, then we have this multiple hit, and this multiple hit would lead to some lung injury. Therefore, this is the difference in the thoracic anesthesia, why the fluid management, the less the better, is more important in thoracic anesthesia than in any other disciplines of anesthesia. So therefore, regarding this multiple hit, we can make it worse with multiple hits. So the second question is how much fluid? If you ask this question with a liberal versus restrictive fluid management, this question would be a trap. This is diabolic. And therefore, it's not very clever to ask this question in that way, because liberal and restrictive are very subjective terms, and this can lead to some mistakes. But now we have this curve. If you check actually this, here. This side is more liberal, and this for more for hypervolemia. The disadvantage of having a hypervolemia is an organ dysfunction. And then on the other side, on the left-hand side, we have the hypovolemia with the restrictive fluid management, and this can lead to hypoperfusion. Therefore, it's always good to be somewhere in between, and this is our goal, this is our target. The question is, how can I find this goal? And maybe it can be also the case that the curve in every patient would look not like this. In the more severe patient, the slope of the curve can become more challenging, and therefore it would be even more important to find the correct point of this goal and avoid hyper and hypovolemia. So what is the goal? What should be optimized? I would start with some studies which is not the goal. This is the optimized study for some 8 or 7 years ago, and afterwards they have done also 5 consequent sub-studies. And in the optimized study, the goal was to keep, or let's say to maximize the cardiac output. It looks actually in 3 points very simple to keep to maximize the cardiac output. But this is one of the sub-study. But to keep the cardiac output in a maximum level, they have used the dopexamine. I cannot make any comment regarding the dopexamine because I have to admit I have never used dopexamine in my whole life. And therefore, as I said, I don't want to make any comment about this study. But probably the goal is not to maximize the cardiac output. So let's go on. What can be the next goal? The next goal can be to avoid the weight gain. We know that with the intraoperative fluids that we give, we can create a weight gain. And this perioperative weight gain is associated with a perioperative mortality. And therefore, if we avoid the weight gain, we can avoid also the perioperative mortality. So let's stay in the zero balance. Then the curve would look something like this. So keep the volume as less as possible, remain as restrictive as possible with a zero balance, and then you can have a better goal. Is it the case? Probably not very, because there are, some pros of restrictive, zero balanced fluid management with no weight gain, and we know that even if you stay restrictive, there is probably no association between the amount of the fluid that you administer during the operation and the perioperative acute kidney injury. And there is probably also no association between the perioperative oliguria and the acute kidney injury. Therefore, let's say restricted. But we also know, especially after the initiation of these rifle score systems, that we have a risk of acute kidney injury during thoracic anesthesia of up to 24%. This is a little exaggerated, but we have to count at least with 10 to 15% of our patients. Therefore, we have to avoid also a kidney injury, because an acute kidney injury during the perioperative period, even if you treat this kidney injury, can become, after some 3-4 months after the surgery, a chronic renal failure. Therefore, you have to avoid the acute kidney injury too. So maybe we have here 2 peaks of the curve. One is the optimal for the kidney, and the other one is optimal for the lung. And this can make all the story much more complicated. So what can we do? What can be the next goal? We have now the more sophisticated monitoring devices, from a lot of companies, and these are quite less invasive, sometimes non-invasive. And we all know, I don't want to go deeply into this story, we can have some goals with the help of these monitors. But it is not the case in the thoracic anesthesia. This is, again, something unique for the thoracic anesthesia, that with the open thorax, we can have some limitations of the monitoring devices. There are a lot of studies showing that we can use also these devices in the thoracic anesthesia, but they have always some limitations, some under certain conditions that you can do this. So probably this is also a difference in the thoracic anesthesia, and probably this is also not the goal that we can have for the fluid management during the thoracic anesthesia. This is the list of Marek in the British Journal of Anesthesia. This is a very interesting article, and we can see here that the best monitoring for the fluid responsiveness is actually not the commercial new ones. It is a very simple one. Patient leg rising and also the rapid fluid challenge. So we can test the fluid responsiveness of the patient with a very simple rapid fluid challenge test. And therefore, this can be a good idea. But it is also quite complicated, because even if the patient is fluid responsive to the rapid fluid challenge, it doesn't mean that this patient is hypovolemic. But it is more complicated, and we'll rather skip this. We have now this ERAS concept, and you can see that the avoidance of fluid overload during thoracic anesthesia is one of the components, but only one of the components of the enhanced recovery after surgery concept during the thoracic anesthesia. So what to do? Forget about the most bottom part of the curve, but in the less or serious patients, we can have this restrictive therapy. In a more serious patient, more critical patient, that we cannot compromise the kidney functions to, we rather have to keep the goal-directed therapy with the optimization of the tissue oxygenation, and by avoidance of the hypotension. We now have also some monitoring devices showing, avoid and to treat the hypotension. And what can be the cause of the hypotension? Oh, the cause of hypotension can be three. One, hypovolemia, which is very rarely the case during the thoracic anesthesia.